Good morning, everyone. Thank you all for joining us today at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by the Center for Substance Use Training and Telementoring, CSTAT at Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick housekeeping notes before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate the bottom of your Zoom window and select the Show Captions option. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Beeville, Texas providers, please make sure you share your name and affiliation in the chat, or if you're joining via phone, please email your phone number and name to beevilletx@utasca.edu. Please know that we are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Anything you put in the chat will not be shared in the recording. We encourage everyone to join by video, especially for the discussion portion in the latter half of the session. That said, regardless of how you're shown up here today, we're just as happy you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you join by computer, your mute button is on the bottom left of your Zoom controls. Or if you're on the phone, just press *6. You can also use the reactions menu in the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. You can also use the chat to share your comments and perspectives. There are a lot of us in this space today, so please keep your comments brief to allow others to share as well. And finally, please note that no protected health information is allowed in either the chat or the discussion, and that includes mentioning names, emails, addresses, dates, pictures, or any information that can easily identify an individual. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it also allows you to access free continuing education credits. We're approved for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credentials. All participants filling out this survey will be automatically entered into a raffle for a $30 Walmart gift card. Today's session will start with a presentation from Jeremiah Goulka on occupational safety and stimulant-involved encounters. Following that, we will hear a case presented by Tarek Waters Haywood. There are a lot of professions represented here today and a lot of experiences and perspectives. I encourage you all to share that in our discussion so that we can all learn from each other in the space. And with that, we're going to start with some introductions. Jeremiah.
Hi, everybody. I'm Jeremiah Goulka, Executive Director of the SHIELD Training Initiative. And we do occupational health and safety trainings for first responder and criminal justice personnel tied to their work responding to the opioid and rising stimulant crises. Looking forward to today and hearing your feedback on the presentation I'm going to give.
Thank you so much. Cynthia.
Good morning. My name is Cynthia Mendiola. I am a retired federal probation officer, and I'm a trainer and coach enjoying this platform, and I hope you do too today. Thank you.
Thank you so much. Dr. Miramontes.
Hello, everyone. Good morning. I'm Dr. Dave Miramontes. I'm the medical director for the San Antonio Fire Department. We provide a whole range of recovery resources as part of our mission, not just 911, but we do a lot of other stuff as well. And one of my paramedics actually presenting today, so hopefully he'll do a great job.
Thank you so much for joining us. Dr. Del Pozo.
Hi, I'm Brandon Del Pozo. I'm a retired New York City police officer. Rose up from patrol to command 2 police precincts there. I'm also the former chief of police of Burlington, Vermont. These days, I am an assistant professor of medicine and public health at Brown University, and it's great to be here and to see everyone.
Thank you so much for joining us. Tarek Haywood.
Hello, I'm Tariq, San Antonio firefighter paramedic. Been in with the city for about 10 years. I currently work with Mobile Integrated Health doing overdose prevention.
Thank you so much for joining us today. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I'm one of the program coordinators here at the Center for Substance Use Training and Telementoring, CSTAT. Welcome, everybody.
Thank you. And with that, we will get on to our didactics. Jeremiah, whenever you're ready, you can take it away.
All right, let me share this screen. All right, cool. You just see the first slide, right?
Yes.
Okay, great. All right, everyone. Well, we're going to jump right in. We're going to talk about occupational safety and stimulant-involved encounters. I've got no disclosure, and these are my views, not UT Health San Antonio's. So what we're doing today is a little different than our usual didactics. Today, we're actually going to just run through an abbreviated version of a new curricula that we're developing at the SHIELD Training Initiative. And this is focused for law enforcement audiences, just to be clear. We may adapt it to other audiences, later. And one of the things we found is that there are a number of mental health de-escalation curricula out there, but not any that, at least as far as we were aware, any evidence-based stimulant response or de-escalation or kind of pre-escalation curricula. And so this is what we've developed here. And I would love to get feedback from folks if we have time to do it today during the session. And otherwise, if you want to reach out by email, we'd just absolutely love people's feedback. We've developed this by talking to a number of behavioral health and law enforcement officers, and just would love to get more feedback. So thank you for listening to this. Appreciate it. So there's, as you all are aware, there's a rise in stimulant use, and that's feeding the polysubstance crisis, the fourth wave of the overdose crisis. There are people consuming opioids and stimulants together, intentionally or unintentionally. And all of this for law enforcement officers, it feeds their stress and burnout on the job. But there's a good news piece, which is that improving knowledge and practices can reduce risk to everybody, reduce stress for officers, and improve their effectiveness. So what we're going to try to get as learning objectives here today are officers should be able to assess their personal level of risk in encounters with individuals experiencing a stimulant-related crisis, develop some strategies on how they can protect themselves and be more effective. And then when they apply these in how they do scene management, coordinate with EMS, and basically, improve the safety for everybody involved. So, there are, police responding to a call, you've got kind of two main encounter situations, or even if it's not a call and you're just seeing something that happens on a beat. The first decision tree is, are you talking about a medical emergency or not? And the medical emergency, I've listed some of those here, heart attack, stroke, heat stroke, seizures, opioid-related overdose, et cetera. That's, engage EMS right away. But for those that are not medically emergent, we're going to talk about some things to do there. And one of the things to recognize why these encounters can be frustrating for officers is that there are a bunch of hurdles they've got to overcome in order to be effective in the encounters. And there are a lot of pressures on them. Time pressure, rushing. This is a really big contributor to making these challenging encounters. So we're going to talk about that. We're going to talk about some common myths, which can, by improving knowledge on there, can help folks be more effective and lower some stress. And then there are communication challenges too, which we'll touch on. So basically, if we can reduce the hurdles somewhat, we can reduce the risks and improve our outcomes. So kind of racing along here. Here's our first myth to provide just on our abbreviated kind of stimulant 101 period here, which is there is a common notion out there that an officer needs to know whether the person is having a mental health crisis or a stimulant crisis. And if it's stimulants, what are they on? Well, it's actually not true. And one of the reasons why we don't need to be able to distinguish between the two is because there's a lot of overlap. So maybe we're talking about a co-occurring situation. And as you can see in these graphs, that there's a lot of overlap between substance use disorder and mental health illnesses. And among those with meth-related SUD, we've got 57% of them, according to one study, having a co-occurring mental illness. So the good news here, and why I was saying we don't really need to be able to disaggregate them, is that the response and the de-escalation strategies you use basically the same. So if you've received, a good evidence-based mental health de-escalation and response training, you can apply what you've learned there. So another thing to note is that the symptoms and the behaviors may mirror each other. So again, being able to specifically diagnose, not necessary, because you can just, we don't need to worry about it. We just know that the symptoms and the behavior might mirror each other. But where we can use this knowledge, importantly, is that one is where you treat the calls as mental health calls, and use those strategies you've already learned. But importantly, not to interrogate somebody, say, what are you on? What have you taken? What have you consumed? You don't need to know these things. It's partly you don't need to know because EMS doesn't need to know. And another is that if that information becomes important, it becomes important later in the process, like at the emergency department. They can do toxicology. They can figure it out then. You don't need it in the moment. The other is that if you ask these questions and interrogate, that actually runs the risk of escalating the person. And so why escalate somebody to get information you don't need to get? Okay, let's move on to the next myths. There's often this concern about stimulants making people really aggressive, and so they're dangerous to interact with. Well, this is kind of a more kind of a complicated issue that needs to be unpacked, but it's useful to recognize that sometimes what you're seeing is not actually aggression per se, but it's reductions in control of bodily movements. So like large or jerky motor movements that may look like really kind of aggressive movements is just a result of having a very activated central nervous system, but not aggression towards you. Another thing to recognize is that there is the what's often called the fight or flight acute stress response. Interestingly, when it's mentioned fight or flight, they tend to leave out there's a third one, which is freeze or hiding. People, when they're having a stimulant crisis, might not be doing the kind of fight or flight. They might just kind of want to hide out. So it's just more complicated. And then also, why are they even having that response? Well, that might be related to hallucinations or paranoia about being followed or chased or threatened. And so recognizing that they're responding to that, you can think about how you approach the situation to not further trigger the person. Okay. Apropos of the aggressiveness is the question about strength. Are the stimulants making people stronger? Well, I don't actually give people like super strength or anything, but it's tied to the stress response. Basically, does the person have an adrenaline rush? So the best way of addressing this, and we're going to talk about this in these strategies, is trying to not trigger any additional adrenaline rush in a person. That way you have less of that kind of likelihood of a fight response. So just be aware. There's another one, this issue of excited delirium. The key notion here is that excited delirium is not actually anymore recognized as a valid medical condition. So several associations, we've listed them here, have said it's not actually a valid diagnosis. It's not based on science. So it's just can't let that be an overriding perception that someone's having this excited delirium, and therefore we need to restrain them. Actually, it turns out that the studies look at deaths connected to what was diagnosed as excited delirium are actually attributed to asphyxiation that was a result of the restraint that they got because somebody thought that they might have excited delirium. So it's this, the causation chains backwards. Best practice is avoid restraint when possible, and we'll talk about that next, because this is a part of this is that is an occupational safety training here, and the greatest moments of risk to an officer is as soon as you start putting hands on somebody. Okay. So now that we've cleared some myths, hopefully, let's pivot to the strategies. The possibly most important one here is slowing down, to giving yourself time to respond. This is really challenging, right? Because a lot of people are going to, officers, and this is going to be an issue and people, all other first responders, is, you've got this perception that you've got to get this task done and move on. Maybe you're getting calls saying, hey, you got to move on. Maybe you just have this sense always that you just need to move on. So the key is to recognize that giving yourself time is a really, really useful way of addressing these encounters. Because the more you rush, the more you demand response and cooperation from the other person, who might not be in a position to really respond or respond well or to follow the actions you're requiring, are more likely to escalate the situation. Plus, the more uncooperative the person is, the more annoyed you're going to get, right? So the rushing escalates, increases the likelihood of escalation, which increases the likelihood of risk. So if you can take the time to assess, like, is there really pressure to move on to the next call? If you are under a tremendous amount, maybe think of some big moment happens and like you got to go, you can see if you can engage EMS and hand it off to them. Or, maybe you need to call in and say, this is going to take a little bit more time. But in fact, the ICAT mental health training, when departments do that, they actually have to make a policy to say, all right, we're going to allow there to be people to have responders have enough time to respond to this encounter to avoid escalation. All right. Now, stay cool. This is the next strategy. This is about you're responding to a call. Say you're an officer, you're responding to a call. You get the dispatch, says you got to go to here. There's a thing happening, and you get like that. Just you got to do this thing. You kind of want to turn on the flashers and hit the accelerator. You've got yet another hit of adrenaline happening to you in your day. When you go in, now you've got this adrenaline spike, your body temperature's gone in, you're ready to kind of go in hot and take care of a situation. But if we know we're dealing with a stimulant-related call or a mental health-related call, if you can basically resist that urge, try to think about what you need to do to kind of keep yourself kind of cool en route, it will really help enable you when you arrive to come in and shape the encounter in a way that is going to be useful to you and everybody else. And this is partly about reducing the kind of burden on you, the adrenaline burden, the stress burden. It's also that the person you're encountering is going to mirror your emotional state, because this is what happens with people. They mirror each other, right? And so if you can go in a cooler state, it's going to it'll avoid the other person kind of escalating from the start based on where you've come in. Literally cooling someone down can also help. Speaking of which, a cool beverage, maybe a little food or something can help. If the person you're encountering with, once you're there, calm it down. It slows down, it disrupts, it allows the person to just take some more time to let the drugs process, let the through the system, let them just settle down in the way they're drinking. A cold drink can help. They may be really hungry. It can just help address the situation. So all of this can lower the kind of energy burden on you. So I should probably also mention here, which I didn't mention at the beginning, is that our training is always done peer-to-peer. So This I'm sure would sound a lot more useful if it was coming from an officer who could, pepper it with, with real analogies and, real world stories. So, context. The next strategy is relating to turning cool. Staying cool is turning down the volume, literally and metaphorically. So for folks who are experiencing a stimulant-related crisis, hallucinations, paranoia, if you've got flashers, you've got sirens going on, this is going to overstimulate them. So if you don't need these, try to avoid using them on your way there. Or certainly as you get close. And, sirens, obviously, you can hear that sound from a distance. The lights you can turn off as you get close. Avoid that kind of auditory and visual stimulation as you arrive. And then in terms of communicating with a person, you can kind of turn down the volume metaphorically by picking one officer to be the communicator. Don't have a whole bunch of people saying different stuff. Have the person who's kind of ready to talk calmly be the communicator. It just limits the number, the quantity of stimulus on the person. And then to hit a point that officers hear a lot in different contexts is how you communicate, the body language, the tone. As this graph shows here, when you think about what you're communicating, that the spoken words is like a small slice of it, but you really give off a huge amount of communication and emotional communication with your tone of your voice, like the volume of your voice, your body language. The more you can kind of turn that volume down, can help slow things down, keeps it cool. We're trying to, which we talk about, people talk about de-escalation strategies all the time. You can see here, we're trying to avoid escalating, not just before it even happens, right? Okay, so then we're talking about, think about the safety issues. There's how close do you want to be? How close do you need to be? Do you need to be laying on hands? Oftentimes, right, this is not necessary. I mean, if it's a intense safety issue, if someone's walking around the middle of the street, whatever they are, you're using your judgment. But if it's not a moment like that, you can, if you can keep your space, create a low-key perimeter around the person. If you've got other officers there, try to get civilians to stay back. Don't like suddenly switch and yell at the civilians and then take a calm voice here. It's like using the you can use space also as a way to kind of be mindful to keep that volume calmer. This also fundamentally keeps the officer safe because it keeps you out of range from being spat on. No one's going to reach in for your weapons. As soon as you touch somebody, that raises the risk. So if you don't have to touch, you're lowering the risk by keeping some distance. This is a number 5 strategy, but this is really a framing one, which is that, officers have a really robust power of discretion. And so leaning into your power of discretion can really help folks think about how they want an interaction to go. How much influence can they have on it? How will they influence it? Are you going to go in a way that escalates? Are you going to try to do your best to not escalate it and then, and give it, all the balancing assessment you can do using the various skills you've gotten, and hopefully skills you've also gotten through mental health training. It's not to say you can't use restraint, but just to, that it's more of a last, it's like the last tool, not an early tool in your tool belt. And that if restraint is going to be used, recognize the risks that go on with it, recognize that it will escalate the situation. If you do restrain, it's important to make sure that the person, you move the person on the other side or have them sit up, because that will ensure that they can breathe. And all right, so we're just going to have a quick sum up. I've raced through this. Like I said, it's a abbreviated version of this curriculum, but it hits a lot of the main points. Slowing things down, staying cool, turn down the volume, influencing with discretion is the way forward. And, EMS is always there to help. So as we have other EMS folks on this, presenting today, they maybe they'll say, hey, stop, don't always rely on us. Why are we always everyone's backstop? But, that's, I guess, the job of police and EMS and fire, first responders are everybody's backstop. So thanks for listening. My email's here. It's also in the chat, jeremiah@shieldinitiative.org. Would love folks' feedback.
Thank you so much, Jeremiah, for this wonderful presentation. I will open up the floor for any questions or comments from our learning community.
Well, I have a comment that kind of support the curriculum and the presentation that Jeremiah, did today. I mean, even on the probation officers setting, where you have individuals coming in and the officer just kind of feels like they use the type of tone of voice they think that they need to assert their authority, and it creates a lot of anxiety and stress on the other person that's receiving. So I think it's really important what he's saying about, coming in with a calming attitude, and the tone of voice that's used. It's very important because it can escalate even in the office setting or out in the field when somebody approaches it in a different manner.
Thank you, Cynthia.
I wanted to ask Jeremiah a question, because I'm deeply interested in this subject. I think when I sum up, I'll say it again, but I think it's really wise that a lot of the good de-escalation wisdom that exists for non-stimulant incidents like works in the case of stimulants, and that you don't have to reinvent the wheel. But are you aware of any research that looks at the specific like physiological differences between stimulant-involved incidents versus general mental health concerns? Because I still worry about things like auditory hallucination that specifically arise from stimulants, and also hypothermia, right, which yields stroke and heart attack in the people like on stimulants. And I know this is a burgeoning research field, but I can't help but think that would influence the de-escalation tactics. So I love the idea that we're starting with the wisdom that you don't have to reinvent the wheel, but do you have any indication that there are differences worth exploring or worth building out in a future curriculum?
That's a good question. I mean, I know there's some, differences, which is, there's a kind of an illegal, behavior, that, that's part of it. So people might be a bit more likely to respond, in ways that they're nervous about police arrival because it's, they've maybe, consumed illicit substances, also that, the things that have been consumed will, their effects will pass, and then the physiological experience will change. In terms of those specifics, like you're asking with like hypothermia, and with things that the way that we were thinking about it, and it was that if someone's demonstrating like in a clear medical emergency, like a hypothermia type situation, then that's a medical emergency. EMS go that way. And so it's for things that are kind of outside of that are in the non-medical emergency situation where there might be more parallel. But I mean, we're, as we're trying to be evidence-based as much as we can. So to the extent that if we're missing some of the evidence base, we need to kind of engage that, and otherwise keep an eye on this growing field.
Yeah, thanks. And I really like this, somebody, as you know, like just by way of disclosure, I'm one of the trainers for SHIELD, and I had a huge de-escalation enterprise in my police department when I was the chief. But I think it's so useful to point out that so part of escalation, you amp the other person up because you're amped up, and by like de-amping yourself, you are actually de-escalating the situation even before you get there. I think that's a really, really important point. Because I remember even as a young cop going lights and sirens to a job where I'm hearing that there's some mayhem going on, I would physically get out of the car amped up. And I wonder how many times that escalated the situation from the get-go. So that was a great point.
Thanks. Thank you, Brandon. Dr. Welke. Sorry, I don't know how to pronounce your name.
Hey, my compliments. You were pretty close, Welke, but Jeremiah, first, thank you. And I will also mention Brandon is at Del Pozo. Point, forgive me, but this goes back to my experience with the the book published 50 years ago called The House of God. And in the case of a cardiac arrest, the first thing you do is take your own pulse. But the training sounds incredibly valuable. Your points, I think, are very valuable. I guess I have to ask, how do you present this material? I remember the early days of advanced cardiac life support and CPR training, where in fact it was all done in a nice clean room and a very, everything was in order, kind of like you were prepared to do it. Doing this in a classroom setting, but solely, I would think would be a little artificial. Do you have a framework or a location, or is some of this presented in real world, or how are you going about the educational process?
Do you mean like, do we have actors who can, we can do like role play and stuff like that?
Well, something that looks a whole lot closer to reality than sitting in a classroom.
Gotcha. Well, unfortunately, we mostly do stuff sitting in a classroom. This comes
Not
in.
that a classroom's bad. I mean, there's a classroom part of this, but doing de-escalation while everybody's sitting in the classroom sometimes seems artificial. I'm sorry, I didn't mean to interrupt, but
No,
go ahead.
that's fine. We there are folks who do like large scale sort of, week long type de-escalation trainings with role play and, a lot more kind of active involvement. This is going to be, while I said this is brief, it's not going to actually be like super longer. It's within the context of an overall occupational and safety and health training that it's usually a 3-hour training, and there's also be a 1-hour version of this. But yeah, unfortunately right now where we are, and it doesn't have that kind of added level of reality or virtual reality. Maybe at some point down the line, if we can get the funding to develop that and figure out how to make it happen, that would be cool.
I did want to add one. Can I jump in to add one thing,
Yeah.
Jeremiah?
Yeah.
Jeremiah referenced ICAT, which is a de-escalation curriculum developed by the Police Executive Research Forum. So I know that SHIELD is a 3-hour module, but ICAT is fairly immersive, and they just got the Buffetts, the Buffetts of Buffett riches to fund a de-escalation training center in Decatur, Illinois, where they have like multi-day immersive scenario-based training as well as didactic training to deliver their de-escalation curriculum. So that does exist, right? I mean, you could take SHIELD as a basis for health-related de-escalation and then complement it with the multi-day de-escalation in Decatur. And I'll put a link in the chat for that.
And that reminds me, Joe Samaro, who was a member of our hub for the last year, his operation has a mental health de-escalation training, and they've got a lot of, it's like a week long, I think. They do a lot of role playing, and he added a point that I meant to add to ours, but he brought it in a previous time, which is, in part of that taking time thing is to have that curiosity to say what's going on. I made a note to make sure that made it into this deck, but I forgot to. Lindsay, you've had your hand up for a long time.
Yeah, thank you. So I love your presentation. I will say that, like, as a peer, right? I worked in Austin, Texas, and they have a mental health police officer training. And I think one of the best things I ever saw was the mental health officer came up and she said she always carried a pack of cigarettes with her, right? Because that was the best way to de-escalate anything, was to offer somebody a cigarette.
Yeah, thank you for that. We're a public health oriented operation, so I feel a little uncomfortable saying that, but yet it seems like an awfully good idea for it as a calming, slow breathing type activity, and harm reduction, smoking versus some cigarette versus something else. Yeah. All right. Thank you for that.
Thank you. This has been a wonderful discussion. Thank you, Jeremiah, again for your wonderful presentation. Please keep the questions coming. We'll in the chat, and we'll address them as we go. In the meanwhile, we will move on to the next part of our session. Karen, if you could please share the announcements from the BVAL Texas. Thank you. Do you have a difficult case that you or your team have encountered? CSAT offers you the opportunity to present any challenge your organization is encountering and receive expert feedback from our hub members. There is no need to prepare a formal presentation. We will be sharing a case form to assist with your presentation. Please email us to cstat@utisca.edu. Next slide. To claim your CMU credit, you must complete the post-session survey in the chat or by email sent after this session. Complete the post-session survey and select yes on the question, are you applying CMU credit for today's ECHO session? Your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you have any questions, please email bwelltx@utisca.edu. Next slide. Our next webinar in the COVID-19 series is happening on Wednesday, April 17th. We will drop the link in the chat. Please do join us. Next slide. And finally, please join us for our next session on Thursday, May 9th. We will be discussing police post-overdose outreach. Thank you. And with that, we will now move on to our case. Karen, please bring up the case form, and Tarek, you can take it away whenever you're ready.
Hello. Okay, so the questions you would like to be addressed is going to be, are minors typically diagnosed with STDs? What are good methods to approach minors into services? The setting and contents of this encounter. MIH received the referral via an overdose report. In the report, medics documented that the mother was in crisis and had no direction on how to help her teenage daughter. I researched the patient's 911 history and began to look for resources that would be able to help this minor and her family. The patient's mother initiated 911 services because her daughter was intoxicated and had smoked THC. The mother told EMS that her daughter had been having a lot of issues with substance abuse. After getting that report in our overdose report, I reached out to the mother, who explained she was facing arrest, being expelled, and kicked out of her AP class or classes due to being caught with a THC tin. I contacted the school detective, explained the situation, confirmed patient had no other history with law enforcement or the school. I created a case by using the patient's behavioral history, the patient's family support, and the patient's remorse for what she did, and advocate on her behalf. What strategies did I employ during the encounter? I approached her with empathy and compassion and focused on what we could do to help the person in the future. Was the agency's standard operating procedure. MIH's overdose prevention program serves as a referral program seeking services for individuals in need of services for substance use. Our procedure is to engage and seek community and clinical services seeking help for substance use. List substances involved and THC pen. List relevant context about the person. Something happened that caused her to act out. Her father was no longer in the picture. Patient had no criminal history, no behavioral history at school. Patient was a straight A student in AP classes. Patient ran away on multiple occasions due to a bad experience at a facility. Their goal to get her in there was to trick her and or try to force her to be at that facility, which is not acceptable, which led her to run away. The barriers that we did face in this encounter, not knowing available resources for the minors with behavioral and substance use issues. I find it difficult to find adult programs and much more challenging finding programs for minors. What went well? The minor was accepting of my help after After the gravity of her situation, the family was grateful and supportive of our developing plan. The school board and court system was supportive and willing to allow our course of action to take place, which ultimately diverted and deflected her from being in the judicial system. What I would do differently if presented with this scenario, I believe that this family needed a navigator to work exclusive with the family, and that is what I was able to provide for them. Having the patient, family, school, and law enforcement allow me to advocate for this individual was the best approach. However, if there is a case manager or social worker that would have the resources to provide this, then that is what I would have done differently. Those are referrals made out to Cicada and Rights Recovery. Thank you.
Thank you so much, Tarek. I will open up the floor for any questions or comments from our community here.
So it's Dr. Miramontes. I'm going to start out with, so the issue is when we have our teenagers, it's really tough to engage them and their family, sometimes getting together a plan to get this young individual diverted away from law enforcement because of their substance use disorder and into treatment. And sometimes the goals of the family are just get this kid out of here. He's in trouble. And they just want them placed. When in fact, sometimes that's probably the cause of the problem, is that inter-family dynamic that's leading this child into a substance use disorder process. So sometimes it really is actually counterproductive to take that child out of the environment separate from the parent, when the family environment may be the place where they can best have success. So in this case, she ran away from the place that she was shoved into, so to speak, which is often the case. But I just bringing that out, that it's not just dealing with one person, you're actually dealing with the whole family dynamic, which may include many members of the family, mom, dad, grandmother, whoever is in the home, which makes this really challenging. And Tariq, I think you brought that's what this case brings out. The challenges of substance use disorder in the teenage population and how to navigate them or encourage or prompt or nudge them into a different therapeutic environment.
Thank you. Any other questions, or maybe anybody has had a similar case that they were able to successfully navigate or help with?
I just wanted to add that Mr. Haywood's, investment in this situation, in the case, and his dedication to try to channel the adolescent to a process that would, keep them out of the criminal justice system and the judicial system. And I think that's excellent work. Commend him for that.
So I had a question, Tarek. Did you know what happened after you made the referrals? Was she able to follow through with the program? What happened? Could you let us know a bit about that?
Yeah, she followed through with peer support through RISE and a program through Cicada. It was a in-school program, so that took away her expulsion. The felony charge that she would have had was dropped, and she's stayed back in her same classes, continued on with getting good grades, was a lot happier, and after getting that help with through RISE and Cicada, we're still doing well.
That's amazing. Thank you. Lindsay.
Yeah, so I think that, I have gone through a situation where I myself was my parents like tricked me into when they institutionalized me when I was young, right? So they just like dropped me off and told me they were taking me somewhere else and then left me at the mental hospital. So like that in itself can be traumatizing, right? For somebody to not have that understanding of what's going on and then have your families drop you off. So I think, from my point of view, like having that discussion with the family, that might be something that might be helpful as well, is really, having that family group counseling and having them be able to talk to each other about that.
I have a question, Tariq. John de la Garza here. Did you have any challenges with getting your patient referred in regards to working with the mother and the child?
As far as finding where to refer her to was the challenge. The mother was just lost for what to do in a whole, but she was very supportive. The grandmother was involved as well. They were supportive. The daughter was supportive of the route that we wanted to take her to get her into more of a peer support type of role versus a clinical role. When we got her into Cicada or we got into Rise, it was more of a peer support. But we had to, for the fire department, we had to go look for a facility or a program that would fit this type of situation. It wasn't readily available to us, and there's not that many that we're aware of.
And what about with law enforcement? Was there any challenges in trying to get them to cooperate with you?
No, there really wasn't. I think everybody on the law enforcement side were on board due to the family support and the lack of criminal or behavioral issues with the school system. And they felt as if I did that her best option was to not be in the system, because then we'd be dealing with her on a different scale, possibly later on as an adult.
Great job on working with this patient.
Thank you.
I see a comment here about not having enough services for youth. I wonder if there are any other resources that people can share in such situations that could help the community to navigate a similar case. Elite Counseling has, thank you, Vanessa. Elite Counseling has outpatient for youth. Any other resources?
I was going to say a little bit of logistics. So a lot of outpatient or freestanding psychiatric facilities, even though their mission is to do some of the drug detox and such, they won't accept kids until they're medically cleared. So unfortunately, a lot of times these young men and women end up in ER to be medically cleared before they get placed, which is not exactly the path that maybe the officer or the individual on scene envisioned. So just keep that, especially if they're acutely intoxicated. A lot of times they get shifted to an ER for medical clearance in a holding status, and then maybe placed or referred on to another inpatient detox or psychiatric facility. that actually is very common. And so our law enforcement folks need to understand that that might be the way you may have to go to get a child. And also bring the parents, because in most facilities, the parent still has to sign consent for treatment and admission. Technically, adolescents can seek for care without their consent, but in reality, consent's required, because unfortunately the facilities require the family member to sign them in so they can bill.
David Arlo. Again, forgive me, can I ask a question though? And your point about medical clearance is not only appropriate, it makes sense for the institutions who are receiving them. I don't know what your circumstances are in San Antonio. I am guessing they're similar to Houston, but taking somebody from medical clearance to most of our emergency departments can easily be a 6 to 8 hour wait, and is not helpful for just about anybody. Do you have any solutions or suggestions, or some other appropriate mechanism? Because I think it's doing a disservice to our law enforcement officers too, to tell them to appropriately take them someplace that's going to not be helpful initially.
Yeah, so in San Antonio, we do have some facilities that will take children, adolescents, and adults